So I mentioned in the previous slide that before you lock the database, you need to make sure you have all the data and that you have done everything to it to make sure it is complete and reliable and valid. So there are a number of steps that you typically go through, and at the end of this we'll talk about the concept of having a checklist, and Proxca has some nice checklist examples in the readings that I've signed to you. But one of the first things you do is make sure you have all the data in the database. You don't want to be, sorry, there's a siren going. You don't want to be missing any pages of data that perhaps were left at the site or not collected or not filled out. You don't want to be missing any eCRF screens. You want to make sure that the site entered all the data for every patient they have. And in particular, you want to know that you have all the critical variable data that was produced for the study. So how do you figure this out? Well, typically you have tracking systems, whether they're paper-based or electronic, and those tracking systems will compare a patient who completed per protocol to all the patient data that you get, and it will tell you if there is data missing, and then you have to determine whether it's validly missing, for example, the patient discontinued, or whether discontinued early, or whether it is data that you need to go after and retrieve. You don't. So let's circle back to that concept of using a quality risk management system to prevent problems, not just to find and fix them. A major component of any quality or risk management system is having a formal plan to correct the problems that do occur and then ensure they don't occur again. We use quality or corrective action plans, also called CAPs, or corrective and preventive action plans, CAPAs, to do this. So CAPs or CAPAs, they're essentially the same thing, but you'll hear both phrases used in the industry, outline what the problem was, how it happened, and most importantly, what will be done to ensure it doesn't happen again. And this is really the key thing. It's one thing to say that you know what went wrong, but what the industry and particularly the regulatory agencies want to know is, what are you going to do to make sure that problem doesn't occur again? And I thought this was kind of interesting. Mary Tara Roth wrote an article in 2011 called Developing a Corrective Action Plan. And in it she includes some examples of the FDA's comments on responses to their audits that they felt were incomplete or insufficient. And this one comment that I've put in here is the FDA says that the site response to an audit is inadequate because the site doesn't say how they'll prevent the problem from occurring in the future. So really your corrective action plan needs to not just say what happened, it needs to outline the actions you're going to take to correct your system and make sure you don't have the problem again. So we just spent some time talking about quality data, but when we started this module we noted that quality is not just the data, it's also the process, and it's managing the risk to that process. So in the industry, in about 10 or 20 years ago, people essentially just did QC at the end of the study and they fixed any errors they found and they said the data is valid, we're going to analyze it. But over the past decade, there has been a move towards a concept of quality management that extends through the development life cycle. So instead of just performing QA and QC at the end of the study and fixing the errors that you find, you actually build quality into the system and you build quality control into the system early. So an excellent example of this is the ICH FDA Q9 guidance for industry, and that's called the Quality Risk Management Guidance. And it's really borrowing from manufacturing guidelines because the manufacturing community got on this idea of life cycle quality management before the clinical research group did. The Q9 emphasizes the point that quality should not be an in-process check, but a proactive identification of potential risks and the development of a plan in advance to mitigate or reduce that risk. So this really is kind of a corollary to that whole concept of risk-based monitoring, because again we're talking about identifying risks before they happen and developing proactive plans to deal with them. And I like this grid here is showing a quality risk management system and the components of it. And this was actually, you'll find a copy of this in the Q9 document, which I'm going to have you read parts of. Another term I want you to be familiar with is root cause analysis, or RCA. And essentially, a root cause analysis is a method of problem solving that tries to identify the primary catalyst for whatever your fault or problem is. So root cause analysis is a cause that, once removed from the problem fault sequence, prevents the final undesirable event from recurring. Essentially, it means if you fix this, you're going to fix or prevent the possibility that the error continues later or occurs later. So how do you do root cause analysis? Well, I've heard people talk about it in terms of the 5 whys, that you ask 5 times why something is happening. And I think that's a good path. But also, with the root cause analysis, I think you can think about it as defining the problem, collecting data on the problem, identifying the possible factors that contributed to it, and in this way being able to drill down to the root cause of the problems and then implement solutions to prevent it from recurring. And so I'll give you an example. I sometimes run into issues where the site will say that they had difficulty getting access to the database. And one of the things that I do is try to do a root cause analysis to determine where the system providing them access broke down. And sometimes we find that it's a technical issue, that there was a glitch in the system, and then we need to fix that. Other times we find that there's a human error. Frequently what we find out is that the site staff were sent an email providing them with the access, and they never opened and utilized the email, and then we have to figure out how to manage that piece of it. Or we might find that there was an error in the understanding on the part of all staff on how to describe what access is needed. And that's something we can fix with training. So for a root cause, I need to find out, is the problem caused by a technical issue? In that case, I need to have a technical solution. Is it a training issue? In which case, we need to do new training. Or is it a human process issue? And in that case, I need to try to build in a system that reduces the possibility human beings will be the source of the error. So root cause analysis is essentially drilling down and figuring out what caused the problem. I think it's very easy to be confused by the terms quality assurance and quality control. They actually mean 2 different things. Quality assurance really tends to be an independent function, and it focuses on the process, while quality control tends to be embedded within a functional area and focuses a little more on the end product. So we're going to take a look at the ICH definitions of quality assurance and quality control and see if that helps us differentiate between the 2. So I'm not going to read the entire E6 definition. I'm going to let you guys do that. But the key concepts here are that quality assurance is independent. So in other words, you don't have a quality assurance auditor residing in the department that they are auditing, because they lose their objectivity. And they are appropriately conducted. So in order to be independent, a QA group needs to sit outside of the group and function they audit. Generally, in the industry, QA groups are going to report directly to a corporate governance position, so perhaps like a CEO or a CIO, or somebody that's not involved on the functional side. Or they're going to report into a regulatory affairs or compliance unit that has a high degree of independence. QA typically performs routine audits on clinical sites, databases, clinical reports, the trial master file, and the data management study file. QA in general looks to see if that end product is correct, true, but really what they're focusing on is, did you follow your SOPs and procedures, and were those procedures adequate? Because if they aren't adequate, if they're not going to produce a good product, then they're essentially not worth following. So QA looks to make sure the procedures were followed and that the procedures were good. So what is quality control and how is it different from quality assurance? ICH E6 defines quality control as periodic operational checks within each functional department that verify that the data are generated, collected, handled, and analyzed, and reported according to protocol, SOPs, and GCPs. So the key concept here is that the QC checks are performed by or within the functional area that did the work. That's different from QA, where the auditors had to be independent of the functional area. And again, they are looking at the clinical data and at the end product of that data. So they're confirming that the data is correct, and they are focused a little less on ensuring that the process itself is adequate. In data management, we tend to focus on quality control of the data entry and query resolution processes. The emphasis is on ensuring that the key variable data collected for every patient is correct. And this goes back to our definition of quality data as being data that is fit for the purpose of analysis. So the focus is on key variables, that's good, but we also want to know if our overall process for handling the data worked. So we tend to take a look at non-key or non-critical data for a randomly selected sample of patients. And as always, we're going to document our QC process in a formal plan, and we want that plan in place before we begin QC. So just like all of the other plans, the DMP, the data entry plan, the data review plan, you have your plan in place before you begin. If you need to modify it, that's fine, but you want to go in with a sense of your scope. This QC plan simply states what data is going to be QC'd, how the QC will be performed, and how we'll evaluate the accuracy of the data or the error rate, what that acceptable error rate is going to be, and what we'll do if that error rate is exceeded. Many companies also create a QC checklist that they base on that plan, a checklist of activities they're going to perform for the QC. After performing the quality control checks, we end by producing a QC report that documents the findings and the error rate. All of this documentation gets archived in the data management study file. Remember that in paper-based systems, we have the data recorded on a paper case report form or source document, and then that is entered into the database by data management. So in a paper-based system, what we really focused on was ensuring the CRF data was entered correctly. And the easiest way to perform this was to get a listing of the data and then compare that listing to the case report form itself. In the example above, I included a screenshot from a very simple QC listing from the REDCap database. It contains common identifier. Remember that in paper-based systems, we have the data recorded on a paper case report form or source document, and then that is entered into the database by data management. So in a paper-based system, what we really focused on was ensuring the CRF data was entered correctly. And the easiest way to perform this was to get a listing of the data and then compare that listing to the case report form itself. In the example above, I included a screenshot from a very simple QC listing from the REDCap database. It contains common identifier and informed consent information. If you look at the listing data for Record 1, you'll see that the date of informed consent is August 1st, 2015. But if you go over and look at the informed consent document, you can see that the date is actually recorded as August 1st, 2014. So the 2 years don't match. You would have marked this as a data entry error. But in EDC systems, the site's already entered the data directly from source documents or some sort of CRF, so there's no CRF for data management to QC against. Instead, quality control of EDC systems focuses on query resolution. So you would look at a sample of the queries to see if they were resolved correctly. For example, do they follow the policies outlined in the data management plan? And was the action they say taken actually taken? On the left, you can see a query I generated and resolved for patient in record number 1. The response I put in states that the pulse of 40 was a typographical error and that the database has been updated to reflect the correct pulse value of 60. But if you look at the screenshot of the database on the right, you can see I never did that and that the pulse is still 40. So that would be an error.